Well, good afternoon, everyone. Thank you very much for signing up to this webinar. I'm delighted to be contributing, and I've been given the opportunity to try and highlight some of the particular challenges to anaesthesia and critical care provision globally as a result of the pandemic. I thought it would be worth starting with a little recap for those of us for whom the last few months have been a bit of a blur. What just happened? I've chosen a few headline events from the last 6 months to help us situate ourselves on this road. So back in January, some of us hadn't even heard of COVID. It hadn't been given that name anyway, but there was a story of an atypical pneumonia emerging in Wuhan, in China, which people in infectious diseases circles were keeping a close eye on. It became evident in early to mid-January that this was a concern, a disease X, if you like, that had been predicted by infectious diseases experts for some time and had the potential to become a serious threat. And that threat was confirmed in late January when human-to-human transmission was documented, or that had been suspected before that, and cases arrived in the US and in Europe. By the end of January, the WHO has declared a public health emergency of international concern. COVID-19 is named as such in February, and also in February the first case arrives in Egypt. By early March, the world is really wide awake to the threat of COVID-19, and the WHO declares it to be a pandemic on the 11th of March. The majority of countries act quickly. Many use social measures such as lockdown to control the spread of COVID-19, but it nonetheless becomes rapidly established in community transmission around the world. In April, pre-symptomatic transmission is confirmed. And all this has happened within 100 days from the first pneumonia of unknown cause being officially documented in Wuhan. Amongst a plethora of other studies that are already active, the first human monoclonal antibody study is launched at this point. Then over the last 2 months, more has been learned about drugs which are and are not effective in treating and preventing COVID-19. Many countries try and come out of lockdown. Some enter, and some are well into a second wave, while others are still trying to control their initial outbreak. There's a huge focus on vaccine trials, with early trial results, including Oxford's, published and promising. And at the end of August, it was thought that 150 vaccines were now in development at some stage. So it has been quite a journey over the last 6 months, and we don't know how long this road is, and we don't know exactly what lies ahead of us. And there is a lot that has been extraordinary. But one of the striking things in particular, I think, has been the level of research and adaptation and the speed with which it's taken place. I've highlighted a few areas on this slide in which there's been particular focus or development over the last few months. And as you can see, they are many and widely varied. But we're left with important unanswered questions too. And at this stage, the current focus in general seems to be in these particular areas. Firstly, how soon do we get a vaccine? And how much will vaccines and/or antibody therapy actually help? We don't yet know definitively how long-lasting the immune response to vaccination is, and we don't know how easy it will be successfully to vaccinate the proportion of the population that we need to effectively halt community transmission. We've got emerging stories of people who've been reinfected. Only a handful so far, and given the number of cases around the world, it really is a very, very small proportion indeed. But it seems to reflect the possibility of reinfection with different strains of the virus, which then links into questions of how quickly this virus will mutate and in what direction. And then thinking more broadly, the other big question for us as a species is how we are going to achieve food and health security over the next year. If the pandemic's going to be controlled, that has to be done globally, across states and institutions which have very different structures and philosophies. There are some attempts. The Gavi organisation is working to promote equitable vaccine access worldwide. But the political and the economic challenges that different countries are facing may well mitigate against effective collaboration, and I think we're seeing hints of that already. Along the same lines, ensuring food security with the outworkings of the pandemic on trade and supply chains will be a challenge in many places, as it has been in some already. So in general, we face some quite challenging questions as a community of human beings and of medics and of surgeons. And particularly for those of us with an interest in global health, I think it's worth just looking at one further general question. At the start of this pandemic, many voices were heard speculating about what would happen in sub-Saharan Africa, what the effect would be of this kind of pandemic on countries which had limited or fragile health systems, given what had happened in countries with better established health systems. And you'll see from this map of incidence from Johns Hopkins data at the beginning of September that certainly the incidence rates at first glance appear very low in Africa, as they do in Southeast Asia. And there's been a lot of theorising as to why that might be the case. Many countries were very quick to initiate testing at some level because many of them have handled high consequence infectious diseases before. Nonetheless, at least part of the explanation for the low rates could be that testing is limited, and in fact we know that that affects data quality all around the world, and certainly has also been the case in the UK and in Europe. But it's possible that other factors are also at play. It's noticeable, for example, that a number of sub-Saharan African countries locked down extremely strictly at the beginning of the pandemic, perhaps recognising that they couldn't afford their health systems to be exposed to the caseload that we've seen in Europe and the United States. And that strategy, of course, also brought morbidity and mortality with it, alongside great economic woe in many places. But it may well have also helped reduce infection rates. Nevertheless, there is some data that suggests that mortality rates have not been as high as might have been expected when you compare them with the rates of past infection demonstrated by antibody testing, and some data from Kenya is referenced in this paper, which was published in Science a few weeks ago. It's an interesting commentary and considers quite a wide variety of possible reasons for that, including lockdown strategies, but also demographics and environmental factors and genetic variants, particularly in the angiotensin II pathway, many of which might well have implications for our worldwide approach to the disease if they can be investigated at more length. So far, these were questions for everyone, and I wanted to include them by way of scene setting for our afternoon together. But my remit is to speak about anaesthesia and intensive care, and so now I'm going to focus on three key areas of priority for the anaesthesia and intensive care community worldwide. So firstly, let's look at direct care of COVID-19 patients. It's still required. Some of us are currently in countries where hospital admission rates have dropped rapidly as a result of social and political measures, but that's not typical of the worldwide experience. Here we've got a graph of deaths per 100,000 population for the 10 worst affected countries in the world as at the beginning of September. And what I want you to notice from this slide is that although some of those curves are flattening out, many really aren't, particularly those in Central and South American countries at the moment. So direct care of COVID patients, including some with severe and life-threatening disease, is still very much a reality. We are in a better place than we were back in February and March with regards to treating COVID, in that a lot of the work that's gone into trialling drugs in hospital context for COVID patients is now coming out with results. I'd recommend you this resource that the BMJ are providing. They call it a living systematic review, which means it's being updated on a frequent basis. And they've made this nice interactive infographic reflecting the strength of evidence for outcomes by comparisons with various different drugs. So here mortality has been selected as the outcome benefit of interest, and the only drug category currently that has a survival benefit over standard care is the glucocorticoids, which is the green dot top right. All the others that you see in pink don't show any difference in effectiveness from standard care. You can have a look to see a little bit more about the information that's available on that infographic. They've summarised a lot of it with things like the thickness of the lines and the placement of the dots on those lines, which is interesting. But in general, this is a really useful resource if you want an overview of what's coming out of the literature worldwide. And then along similar lines, I'd also recommend the Oxford Centre for Evidence-Based Medicine's COVID pages, which analyse data from COVID studies. They do have a lot of UK-centric information as well, but when you're looking for what treatments are effective, the scope of this analysis is global. We find that we have more options than we once did for drugs, particularly glucocorticoids. We have a bit of data around proning, and particularly in awake proning in COVID. We also have some negatives. It seems unlikely that hydroxychloroquine is as useful as we once hoped, and the jury is still out on remdesivir, but plenty of work is continuing to evaluate existing drugs and to develop new ones. But the mainstay for the intensivists of management for moderate to severe COVID is still supportive. Depending what denominator you use, oxygen is probably required by 15 to 20% of patients who have symptomatic COVID-19, and mechanical ventilation probably by around 3 to 5% of those admitted to hospital. Neither of those management modalities, oxygen or ventilation, are readily available to all populations around the world. You may well remember back in March, April and May, we saw an enormous number of headlines along these lines. Every company and innovator seemed to be making some sort of low-cost ventilator, and there was considerable traffic and trade in ventilators, the fear having been that this would be the limiting factor for patient and population survival. What seemed to be less well recognised in the general media, probably because it was a harder problem to face, was that ventilators are not much good without infrastructural development. In some UK hospitals, oxygen supply became a problem before ventilators did. In the low-resource setting, the media focus on ventilator donations didn't reflect the challenge of safely providing ventilation to patients in places that had never done it before. So just to highlight some of the wider needs around ventilation, if you're going to run a patient on a ventilator and get them off it again, you need an expert operator of that ventilator with training. They need PPE to stay safe. And you need somebody, not necessarily the same person, available who has intubation skills. Most ventilators need some pressurised driving gas in addition to the oxygen that the patient requires. They need reliable electricity, and they need to be able to handle the kind of lungs that people develop with severe COVID-19. The simple bag squeezers, which have been developed all around the world, may have value as a temporising strategy, but they don't help the patients with severe lung disease. And then in the longer run, to keep ventilators going, you need consumables and maintenance, which may be harder to access for centres without experienced biomedical engineering departments. So all of these infrastructural needs need to be addressed if giving a ventilator to a hospital is actually going to make a difference. In fact, what grabs far fewer headlines in the media, but which would be of benefit to far more patients, would be adequate oxygen provision in hospital facilities around the world. There's already been a lot of work pre-COVID, particularly by our paediatrician colleagues, as well as anaesthetists and surgeons, looking at the availability of oxygen around the world. And this study is a typical example, reflecting the availability of oxygen in 132 facilities in 8 low and middle income countries around the world. And it demonstrates clearly that if you are a patient in one of these centres, you cannot count on oxygen being provided to you if you need it. Efforts are being made to raise awareness in the scientific and wider media about the relative value of oxygen in fighting COVID-19, as well as all its other benefits to patients in hospitals. But as yet, it hasn't acquired the media level of attention that ventilators did. So I think it's fair to say that as anaesthetists and critical care community involved with the most severely affected patients from COVID-19, those who require hospital and critical care support, direct care of those patients is still an area of challenge for us, in particular the slightly unhelpful focus on ventilator provision without supporting infrastructure, in contrast to the lack of focus on oxygen provision, which is relevant to far more patients. And of course, we still need progress on more effective drugs. The second area of challenge for us as a community is around the ability to provide surge capacity within our hospitals. As we all know from our own experience, difficult choices have been made everywhere. The surge capacity has to encompass physical space, equipment resources, pharmaceutical resources, and human resources. In particular, related to pharmaceuticals, the knock-on effects of the pandemic on international trade and manufacturing do affect drug availability, and the current pace of the pandemic in India, which is the biggest provider of generic medicines in the world, is a huge global concern from that point of view. In many centres, the solution to providing surge capacity has been to stop or slow down the pace of elective surgical work, which means that operating theatre resources in all those categories can be diverted to treat COVID-19 patients. Clearly, that resource is much more limited in centres that don't undertake a lot of elective surgery to start with. This is a study which I found interesting. It attempted to quantify the emergency to elective surgery ratio in centres around the world, primarily at the time as an indicator for surgical care access. This is a pre-COVID paper. But it's certainly of use in illustrating a sense of how much centres in different locations are likely to be able to drop elective surgery should they choose to, in order to increase their capacity to care for COVID patients. A centre with a higher EE ratio does proportionately more emergent surgery and correspondingly, one assumes, has less surge capacity related to suspending elective services. That's particularly the case from this study in sub-Saharan Africa. Of course, whether or how much elective surgery should be stopped, if there is that luxury, in order to facilitate ventilation and care for COVID-19 patients, is an ethical issue which isn't at all straightforward. Different regions with different situations are likely to make different choices at different times, and the choices that are made will clearly also have longer-term implications for population health, which have yet to work their way out. The third, and I would suggest longest term challenge for anaesthesia and critical care communities around the world, is the impact of the pandemic on the workforce. It's likely to be multifactorial. Some will suffer from COVID themselves, either because they have been infected in the community or because they have been infected through their work. Some will die. Many, if not all, will have their training interrupted or abandoned, or have difficulties accessing their training, getting to it geographically, and there may be recruitment issues as well. Countries which have a strong training infrastructure and strong professional groups may be able to develop strategies to deal with this, to make up time where training's been affected, or to put increased resources into recruitment and access capacity for trainees. In countries where the anaesthesia workforce was already stretched, I think the consequences of workforce impact for safe surgical provision in the long run are potentially very bleak. So those are three challenges that I think that the anaesthesia and critical care communities are facing. And I suppose it just remains now to ask where next. Well, within anaesthesia and critical care, I think the two key areas to focus on over the next months to years will be helping to develop facilities capacity for oxygen therapy, which clearly has wider benefits than just the ability to respond to the pandemic, and building the workforce or rebuilding it. We can be thinking about developing strategies for how to provide an adequate number of anaesthesia providers to ensure safe surgical care in the years to come. For all of us, whether we're anaesthetists, surgeons, obstetricians, or any other clinical or non-clinical interested party, let's recognise that we're still in the middle of the journey. In the last 6 months, we've seen extraordinary collaboration and cooperation, adaptation and recognition of the global nature of this pandemic. But it's not over, and I think the story of the next 6 to 12 months will be the fight for health equity, and particularly in the area of global surgery, which will be hit hard by the effects of this pandemic. Let's keep collaborating and communicating to ensure adequate access to healthcare for all our populations, whether that means vaccination, access to theatre for a caesarean section, ability to get your broken leg fixed, or the chance of receiving the critical care that might keep you alive after contracting an infectious disease. Thank you very much for your time.